As the American population continues to grow and age and current internists retire, the need for hometown doctors is skyrocketing. How will we fill the need for future care? The doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Welcome to On Call Television. Years ago, we called them general practitioners. They were the guys who had a broad knowledge base to take on almost every problem. They were the ones you would go to with an unknown or an undefined problem, asking the doctor to sort out what to do next. Patients would start there. That's why we call it primary care. With the need to know more and therefore to have more training, the whole system has evolved such that we still have general practitioners, but now this role is mostly provided by family physicians, pediatricians, and general internists. In Canada, 50% of all doctors are trained to fulfill this primary care role. But over the time in the U.S., we have let that percentage drop to about 30%, and that number is in danger of continuing to fall. The reasons for this decline in primary care doctors is myriad and will be discussed tonight. The importance to this issue is best realized as we learn that studies have found that costs are reduced and outcomes improved when patients have a primary care doctor and start there. Say it again, the ideal is that every person has their own doctor, their own medical home. But right now we're not producing enough of these kinds of doctors. Well, here to discuss how we got into this trouble and what we should do to fix it are two perfect experts. Dr. David Kapaska is a graduate of the U.S. Air Force Academy and went on to earn a Master's of Business Administration degree from Southern Illinois University and a medical degree from the University of Osteopathic Medicine in Des Moines, Iowa. He served as a pilot in the U.S. Air Force before embarking on a career in both business and medical realms, and after 10 years of medical practice and family medicine, Dr. Kapaska began his administrative role and presently is the regional president and the CEO of Avera McKennan Hospital and University Health Center. Dr. Bruce Vogt is a graduate of University of South Dakota, where he went to school with me and we were classmates in college. He earned his Bachelor of Science in Medicine degree at the USD School of Medicine and a medical degree from the University of Nebraska College of Medicine. He did his residency in family medicine at the Sioux Falls Family Medicine Residency Program and practiced family medicine while taking on the role of teacher there. He's presently full professor of family medicine at the Sanford School of Medicine at USD and presently is the chair of family medicine. Also, he has the role of program director for the South Dakota Area Health Education Center. Gentlemen, welcome. And thanks for joining us about this important topic. Dave, tell us a little bit about yourself. Now you're the head of McKennan Hospital.
Well, thank you. It's a privilege to be here. I think that my medical career actually began as I used to deliver pharmacy flyers when I was a young kid, and I always thought I'd be a pharmacist. I went to the Air Force Academy, and there is no pharmacy school there, so I went off in a different direction. But flew a lot of medevac flights out of Vietnam and
Wow.
in the South Pacific, and really got engaged with what medicine was all about, and I knew that was my passion. And so
went on to medical school.
I went on to medical school and practiced family practice in a very small town to start with, Sac City, Iowa, which is east of Sioux City, about 75 miles. Then I moved to Ankeny, Iowa, just north of Des Moines, to help a friend who had had a stroke and take over his practice. Then moved to Sioux Falls to take on an administrative role at Avera, McKennan. I've been there for the better part of 12 years.
That's great. And Bruce, tell us a little bit about your story.
I'm a native of Yankton, and as you said, I went to the University of South Dakota, and then went into the first 2 years of medical school there, just as you, before we had a 4-year degree granting school, and then, as we all had to do in those days, transferred, and I went to the University of Nebraska and came back to South Dakota, training in Sioux Falls, as you said, in the family medicine program there. And I was in private practice for 4 years, but I always thought maybe I'd get involved in teaching. And an opportunity arose where actually both I and 2 other colleagues at the same time went into teaching in the family medicine residency program, and then eventually ended up in the school proper as Dean of Graduate Medical Education, and subsequently chair of the Department of Family Medicine. So,
yeah, and you were the editor for the South Dakota Journal of Medicine.
For 6 years I was either editor or co-editor. Yes.
So I mean, a very competent guy, and was a classmate of mine dissecting cats together. Yeah.
I took that cat home either Thanksgiving or Christmas.
I remember that.
You probably were probably making me do the work,
Why don't you tell us a little bit about what you think? We'll start with your perspective as representing the School of Medicine with this particular issue.
Well, I think, there's a lack of primary care physicians in the nation as a whole, and in rural areas it's even worse, and not getting any better. We've had the problem since I was in practice, first started practice, and so we need to continue to address it. And it's, as I said, even greater problem in the rural parts of our state. And there are a lot of reasons that students choose or don't choose to go into one of the primary care fields. And I think one of the things that we need to do within the school is to prepare our students so they're competent to go any place, show them that they can have an extremely rewarding career in a field like family medicine or general internal medicine or pediatrics, and that they can survive in the rural area. Rural practice is much different nowadays than it was when we first went to medical school. Yeah. It's tremendously different, and we need to show students that.
They can have a decent lifestyle, they have,
absolutely.
And they can do quality care.
Exactly, yeah.
And your perspective on the issue of primary care inadequacy numbers as the head of a hospital system?
Well, all of us obviously are primary care physicians, so
yes.
We hold that at our core. But I think as a hospital administrator now, I actually have 13 other hospitals beside Avera McKennan that are in my region that are all critical access hospitals. They're small. They're in small communities, relatively, and they depend on primary care physicians. And a part of my role and my team's role is to make sure that we have adequate, well-trained physicians in each of those communities to serve. And that's not an easy thing necessarily, because young people have lots of options. And I think technology can work for us or work against us. The technology of the last few years has focused on having big machines that do amazing things. Big machines don't answer all the questions. Big minds, good minds answer a lot of questions before you need the big machines. And I think when you train with big machines and then need to and look at going to a smaller place that doesn't have all of that technology, you can be nervous about that. So a part of this is having our young people experience how much they can do with their eyes and ears and hands.
And stethoscope.
Exactly. Before they have to order the large tests, the expensive tests and such. They all have their place, and they're all very important, but I think they're important in a transitional mode from first looking and then using technology that might be necessary.
Well, and you first have to teach. Students need to think. Doctors need to think. You know, it's not all about seeing every disease out there. There's no way that every medical student, every resident is going to see every disease process out there. They need to know how to manage the patient. They need to know how to approach the patient, how to think through a problem, and get the right resources to help the patient, whether it's he or she, himself or herself, being able to take care of the patient, or whether they need a subspecialist.
And I think they're missing a bet not going into primary care. It's I think the world's greatest job that a person can possibly have. And to talk a little bit more about this and get the perspective, one more perspective, we have on the line on new technology, speaking of technology, is Dr. Allison. Rob Allison is a general internist like me, who is from Pierre, practicing medicine, but he's also the president of the South Dakota State Medical Association. A brilliant guy and a great friend, and Rob, thank you. You know, he trained in Nebraska, Bruce.
I know.
I don't know. Other than that, he's a really pretty good guy. So but Rob, what about this issue, and what is the perspective of the South Dakota State Medical Association regarding this dilemma and issue?
Yeah, I mean, our main purpose was to educate people right away. We were on a task force with the governor, and we were to give the physician side and how do we advocate for patients as our mission for the medical association. And so we participated on 3 different meetings, one by teleconference, and there'll be a final report coming out probably next week, where we addressed, cost issues, access to care. We reviewed the data like Bruce and Dave said, and we really tried to put together the best possible picture for the legislators and have them make the tough decisions, funding and costs. For example, do we recommend expansion of residency? Do we recommend expansion of medical student slots? How do we support the teaching agenda of the School of Medicine? So all those topics kind of came through that task force, and were pretty much supported by the Medical Association.
So did you, what would be the most important thing that our audience right now should take home? I mean, is it a message that they should call the governor right now and demand that we do this XYZ? Should they send their kids to medical school? Should they be frightened? What would you want the listener to do?
As a primary care physician, I realize my job is becoming harder and harder to do, and we need help to do it. I think the best people to provide that care are primary care physicians, but we truly value the resources from advanced nurse practitioners and physician assistants, and we worked in coalition with them to figure out ways to get patients seen. So I do see a desperation with only a very small percentages of students going into primary care. These students are smart. They have large amounts of debts from medical school, $200,000, and they want to pay off their loans, and they want to be in an environment where they can have all the technology and do what they want. But we need to somehow come back to that concept of you can do everything in primary care. The medical home is going to be a big topic, and how does that expand with the Affordable Care Act? How does the state deal with Medicaid? And so there's opportunities in primary care that we may need to maintain the role of the physician in that care and the physician-led team.
I think that's a great point. He mentioned the fact that people come out of medical school with a debt of $200,000, and they're looking at options that they could go into, and primary care is, I mean, it pays pretty well. I am a well-paid guy, but we're on the bottom rung as far as doctors pay. What's your comment on that?
Yeah, well, with our school, I think the average debt from medical school is $140,000. Now that doesn't take into account if they have debt from college years.
Right.
You know, the thing I would say though is a few years ago, our department looked at the data on students and why they chose or didn't choose something like family medicine, and there was still a good amount of altruism, you know, and also an issue of role model. Yes, and I mean, yes, salary's a factor and debt's a factor. Physicians are paid well. Nobody's going to starve.
Nobody.
No, but our students. I think Rob mentioned role modeling, words to that effect, and role modeling is a big issue. And Dave, you were talking about the training in tertiary care centers. That's exactly right, and students will see those doctors and say, I want to be like her, or I want to be like him, and there's nothing wrong with that, but we want to show them that you can be like her or him out in rural areas too.
Right.
You know, our school has always had an emphasis. I mean, it was developed specifically to produce family physicians for the state of South Dakota, and we still have that in our mission statement today.
But it's more than the mission statement, Bruce. I'm going to argue we have in this state a school that brings our students to see primary care doctors out in the real world
yes,
more than anyone else. Before we I need to do one more thing. Rob, before you leave us, I want to ask you why you went into primary care. What made you, or if you're still there, what made you decide to be a general internist?
It was actually mentoring. My resident at the University of Nebraska Med Center said I did things well in medicine, and I did an outpatient rural track in Grand Island, Nebraska, and I learned how to do colonoscopies and stress tests and read echocardiograms. And then I had a partner who I trained with, Phil Meyer from here, had a real commitment back to Pierre. He said, you want to practice with me in a small town and do it all? And I've done that for 14 years.
Thank you for joining us, Rob, and we appreciate it, and we're glad you're out there, and I know the people of Pierre are happy that you're there, and that's the truth. Dave, your response to that particular
Well,
thing.
I think one of the real challenges, and I always chuckle a little bit at I don't chuckle at it, but debt. I remember complaining about my debt the first year I was out of medical school, and a farmer reminded me that his combine cost $50,000 more than my debt. So I stopped complaining about that at that point. But I think one of the things that we all need to realize is that it's stated that medical information doubles every 2.5 to 3 years. That's frightening for young people because you know, by the time you get out of medical school, a lot of things have changed already. By the time you get out of residency, they've changed some more. And I think that's one of the pieces that encourages indirectly people to stay close to experts all the time, because it's less challenging, if you would, in some ways, to know that you have that help close by.
Well, you know, our job is to know everything about everything.
Exactly.
And we have these specialists that we know to send to get this extra care, but we have to know all the nuances of cardiology, of nephrology.
And yet you don't have to know every single thing. And you know, there's this dichotomy that you see where students will say, how can I possibly know everything I need to know in family medicine? And then on the other hand, they'll say, well, all I'm going to see is colds.
Yeah.
You know, and you know, neither is.
But that's not true.
Yeah,
no.
right. That's right.
See all these.
That's right.
This most glorious rainbow of different illnesses when you practice.
Right. And in a rural area, and one of the things I want to talk about is the new Frontier in Rural Medicine program, which does relate to role modeling and mentoring and that sort of thing. But you know, one of the things in a place like Sioux Falls, a lot of patients will self-select what doctor they go to. I mean, they have, most people will have their primary care doctor and such, but they may also think, well, gee, I have this, I think I need to see an endocrinologist, and I have one, you know, in the building down the street and such. That doesn't happen in rural areas. You know, anything walks in the door. I mean, not that that doesn't happen in Sioux Falls or Rapid City, some of our other larger towns, but the fact of the matter is, in rural areas, it's so very, very, very true. One of the things, when I was talking about the family medicine mission, that sort of thing, we've always had an emphasis, as I said. And we've had a preceptorship, which you and I went on, you know, at the end of our second year.
Joseph Mugley in Madison, South Dakota. Where'd you go?
Ted Holm, and Paul Holm in Huron. That's right. Just had our 65th preceptorship. We've also had a required 4th year family medicine rural experience since the beginning of the 4-year school. Those 1-month experiences are wonderful, but you can't get the full flavor of what it's like to be in a rural area. Dispel some of the myths, because there are a lot of myths, what's going on. And now we're developing what we're calling Frontier and Rural Medicine program. We're up to 6 students will spend 9 months of their 3rd year medical school, the most critical time for a student to decide what she or he is going to go into in a rural community. And we're really excited about it. And they're going to be able to be engaged in the community, see what the rewards are of being a small town physician.
Have a small town physician mentor. The mentoring is it, isn't it?
Exactly.
It is.
Right.
And the other thing that works for us, I think, is that so much of our population is really rural. Most of us came from very small places that our mentors started when we were very young. Yeah. And the doctors that we saw were primary care physicians. Yeah. That's really all there were in my area anyway. That's all I ever saw and all I ever wanted to be for that reason. Now you have other experiences along the way that can bend that a little bit, but so I think we just have to encourage what's been encouraged through their own experiences through their life up to that time.
I have to say this, that Dr. Bell was my mentor. I grew up in that experience of seeing what his practice and life was like. To me, he was my hero next to my dad.
Yes.
And that's a great experience. But let's talk 1 minute more before we take some questions about the issue of quality and cost. And so I know that in the United States, they looked at the quality of health care and they've looked at the cost of health care. Where do we stand? You know the answer to this. Where do we in South Dakota stand as far as quality and as far as cost? Because we have probably the highest level of family physician and generalists versus specialists than anywhere else in the country.
Well, nationally, I mean, we talk about the fact that our nation is probably 19th or 20th compared to other industrialized nations around the world. I think there are a lot of reasons for that probably aren't well explained just by that number. But in South Dakota, our quality level and our quality is very high and our cost is very low, and very much oriented to primary care physicians providing that care throughout the regions of our state. And so I think that primary care physicians hold costs down in a way that we need to do moving forward.
In the country?
Yes.
Right. I think if every state looked like South Dakota, the ranking would be better.
Yeah, it would be a lot better than 19th in the world, wouldn't we?
Yes.
But we're not just talking out of our hat on that. They've got numbers. I mean, we've got numbers. The quality measurements. We have parameters. They look at what particular meds we use when there's a heart attack. How fast is an antibiotic started with pneumonia? That the quality measures were right on the top, and the cost per is on the bottom.
Yes.
Right.
Go figure.
Indeed.
Indeed. So let's take the first question. Why doesn't the USD school train more family physicians?
Well, we have done a really very, very good job over the years. If you look at us, we're at the top of the nation in how we've done over the years. But we don't do as much as we should. And there are a lot of reasons for it that we've touched on tonight. But that's why we're doing things like the Frontier and Rural Medicine program. Certainly, the students get exposed plenty within the School of Medicine, and we're just continuing to try to build upon that.
Here is another quick question. We've got just a short time. I use my OBGYN as my primary care physician. Is this a good idea?
I think that it certainly can be for a young woman. I think that OBGYNs are primary care physicians at that point in time.
They are.
Yes.
I agree with you in that role.
Yes.
Although many of them go on to do mostly GYN surgery.
Exactly.
And I mean, you get stretched because they're asking themselves to do everything, and they are a stretched group. Comment?
Yeah, no.
And what we'll get back to this in a minute. There are many who are concerned about the coming shortage of primary care doctors. Not surprisingly, we found someone who is presently a small community physician and visited with him about the problems that push doctors away from becoming a family practitioner and what he sees as the discussions we need to have.
What's coming out nowadays? $100,000 and $300,000 worth of debt. And the problem with that is when you're in family practice and you start out at $140,000 a year and you have all these other expenses, it makes it very difficult to make ends meet. So a lot of these kids will go into orthopedics or cardiology where there's a lot more procedures. And with the procedures, of course, they're reimbursed a lot better. And they can pay that big note back off a lot sooner rather than wait for many years down the road to finally get this paid off. And there's a lot of reluctance on the behalf of specialists sometimes to train family practice doctors in procedures because they would like to keep those procedures for themselves. In addition to that fact, there's a lot of liability concerns and issues that some of these specialists are concerned about if they let family practice residents do some of these procedures. So it's very, I guess the point is it's very multifactorial, the issues with declining numbers in rural medicine. A lot of these residents, most of these residents are trained in bigger cities. And so there is a reluctance of these young kids to come out of that setting and that environment where you've got a cardiologist or an ENT specialist or an orthopedic surgeon right down the hallway. It's very difficult for them to leave that environment when they go out in rural America and all of a sudden they are the cardiologist, they are the orthopedic surgeon, they are the neurosurgeon. They have to do many things that are done in the big city. So it presents a challenge, and the challenge that medicine has is being able to train these young students so when they come out into a rural area, they feel free and capable of doing life-saving procedures. Right now, where there's 21 doctors per 10,000 patients, and in 2020, there will be 21 doctors for 30,000 patients. There will be a $90,000 or 90,000 physician shortage in the year 2020. And those are numbers I just looked at CDC before we did this interview, so it's those are pretty staggering numbers. And the question is, what do we do with our baby boomers when they hit? People say we have this big wave of baby boomers coming. Well, if you really look at the numbers, it's more of a tidal wave. It's a tsunami coming. I think at this stage of the game, the big crisis that we've got coming on, I think everything's on the table. I think chiropractic care is on the table. Mid-levels are on the table, PAs, nurse practitioners. When you've got this big of a healthcare crisis coming, I mean, it's, utilizing all aspects of healthcare is going to be mandatory. We're not going to have a lot of choice. And I think that there's some very capable caregivers out there. There are nurse mid-levels, there are chiropractors, there are optometrists. But those are things that we have to have this conversation about. And a very serious conversation in the coming years. You're going to have 90,000 doctor shortage out there, primary care. We've got to figure out how we're going to fill that void.
Please call in your questions about tonight's topic. Call 1-888-376-6225. You can also email them to questions@oncalltelevision.com. So that's 1-888-376-6225. We like your questions. Thank you, Dr. Gary Bruning from Flandreau. What a beautiful perspective. Of course, the classic family physician who was asked to give an interview, and he did his research, read about the thing, had the numbers. The numbers he was talking about of the tsunami coming, what are the numbers in South Dakota?
Well, Rick, I haven't looked at the stats within the last couple of years, but the last time I checked, if you look at family physicians alone, that about a third of the family physicians in our state are 50 and older, and about 2/3 are 40 and older. That doesn't leave a real long career, and this at a time when fewer numbers are going into family medicine. And the figures for the internists are about the same.
Yeah, the numbers for internists.
Very similar.
And at the same time, the boomers getting older.
Right.
I mean, we're going to have a tsunami, as he said, are we not?
Well, I think one of the things that Gary talked about is how do we utilize all of the resources available to us. And I chuckle sometimes because when I applied to medical school, I had my MBA already, and the medical schools would not accept the grades for my MBA. They said it was irrelevant. And I chuckled then a little bit, and I chuckle now because the reality is that there's so much knowledge out there that we have to supposedly put under our hats and be ready to use, that it's impossible. It really is. But what is possible is that we manage all of the opportunities that we have to care for folks in a sequential way. He talked about nurse practitioners and PAs. How do we integrate them into our practice? Much of our practice is designed today by the way we're paid. If we don't do it a certain way, we don't get paid. If we do it a certain way, we get paid, and don't let the two mix. I think as we look forward, if we were just to take care of a population of people, if you had 2,000 patients to care for here in Brookings, and it made no difference how you did that, I think you could figure out a system that you could be more accessible, more available, more focused on the really tough cases, and really make a difference maximizing the capability of everyone around you, rather than being a craftsman, as were trained, that I do all the work, and you come here, I'll do the work and turn you loose. And I think we can do better, and I think we'll have to, just because of the numbers.
And relating to the numbers, and it gets back also to the question about why we don't produce more family physicians and such. The Frontier in Rural Medicine program that I talked about came out of Governor Dugard's proposal, part of his WINS program, which is on workforce development. But we increased our class size specifically for this Frontier in Rural Medicine program. Another thing that's happened as well is that the PA program, which has been a program of 20 students, are now going to 25 students. And the other thing, where it used to be half were in-state, half out-of-state, now 20 of the 25 will be South Dakotans.
So I think we're going in the right direction, and I think in South Dakota in particular, we're good. It's just that we do have old doctors. And there is going to be that crisis. I wanted to make a comment about nurse practitioners, PAs. I know you're the medical director of the PA program here, and that you support these homes. Yes. The idea that we're going to have a medical home and it's going to be a team. If the problem I have right now, I'm overwhelmed by making sure that I do my medical computer thing exactly right, and I push all enough buttons that I can call it a 99214 instead of a 99213. Yes. And it takes more time and away from the patients. It really does.
Yes.
And I think that's a big problem.
I had a friend that was in Africa recently and working in a remote clinic. He saw 127 patients in one day.
And you asked him how did
and he said it worked fine, but he did not have to do 4 hours of documentation or 8 hours. They wrote down the problem, wrote down the medicine, and went on to the next person. And so they maximized the utility of that person, of the physician, and could see hundreds of people rather than, you and I, if we see 30 a day, I mean, that is a huge people.
Yeah.
Right now I have to, I am also the scribe. Yes. I am the
you become the transcriptionist.
Yes.
You didn't used to be the transcriptionist.
No.
And of course, I'm the bad guy that makes you do it.
Right.
You are the guy that you.
But electronic health records are extremely powerful, and the benefits certainly outweigh the problems with it and such. But it is more time consuming, and I don't like the idea of a computer screen in the room, with the patient and such. But that's the way it is. I mean, there are also positives, being able to show them an X-ray or whatever.
Right. There are a lot of positives.
There are a lot of positives and safety issues.
The app will improve. We'll get a killer app. Things are going to improve. I do think that I have a PA student working with me, answering the phones right now, I might tell you. And I have a nurse practitioner that works with me. I'm married to a nurse practitioner. Yes. So and I taught PAs at Emory.
Sure.
So I think it's a wonderful thing. But I think that they, together as a team, will be able to do this.
Exactly. And it even goes beyond who is in your clinic. We've been developing at Avera an e-system of help, if you would, to bring tertiary care or the high-end subspecialty care to the smallest of locations in support of the patients there, number one, but especially in support of the physician who may train in a tertiary center that says, I cannot survive in a place by myself with no help.
And I just have to say a huge thing about ICU for our community. Now, I can take a sick patient and the nurse will say, okay, we can keep him. Over the last, at first they used to do that in the 80s, but in the 90s they started saying, no, we're not going to take this patient. I don't have time. Yes. I'm overworked. I don't know, and this is a sick patient. I don't know how to handle him. Yes. Now I can put him in the EICU. The nurse has the support of an intensive care physician and nurse practitioner, PA, and their nursing team watching our patient together through the night. It's been a huge thing for our community because the nurses are better. Yes. Our hospital is better.
And much smaller communities as well. And when you get back to this issue of students being concerned about, they train in this tertiary care center and all these subspecialists, and I was kidding Dave, you know, there's an MRI around every corner of the hospital, you know, in Sioux Falls. I mean, this is tremendous support to them, and they can see what the capabilities are and such. The technology is amazing. It's like having the doctor, the ER doctor in the room with you.
The same thing with the ER, that's right, the ER.
Yes, right. And it's just one of those aspects of how rural medicine has changed, you know, so much. And they need to be exposed to that to see that. And the fact of the matter is, other things that it's very typical within a lot of rural communities that they will have specialists that will come to their community, whether it's once a week or once a month, depending on the need. It's tremendous support for that as well.
Tremendous support, and it's great to practice in Brookings because we get this. The way payments are made to various doctors or medical organizations are thought by some to be out of balance. What are the consequences of this disparity, and does the Obamacare, the ACA, address that?
Hello, I'm Matthew Owens. I'm a family physician up in Redfield, South Dakota. I practice medicine in a critical access care hospital in a federally designated rural frontier county. We've been experiencing, even prior to my arrival, a chronic recurrent shortage of primary care physicians. I'm not new at the healthcare game. I started as U.S. Army medic in 1981, took my first pager almost 31 years ago. Now moving on as a physician, carrying almost a similar pager or being on call, I find that in the United States we're just not doing a very good job of producing primary care physicians that are willing to work in the medically underserved areas. Medical underserved areas 20 years ago meant rural. Medical underserved areas now can include inner city, even moderate-sized city. Our problem that we're dealing with in the United States is we pay for services of invasive type procedures extremely well. We do not pay for preventative services. We do not pay for cognitive services. We need to move to our healthcare system that pays for people to actually sit down and think about what are we buying, what is the outcome of this procedure, and how could we have prevented that procedure from even needing to happen. As far as providing those services, yes, there's some improvement we can do with outsourcing as far as remote technologies. There's things we can do like currently Avera is doing with EER. Yes, they're helpful, but it does not cure the underlying problem of where some healthcare providers are being paid by a factor of 10 compared to doing the same sort of work in a rural environment. There's the government, the current situation is with Medicare and Medicaid reimbursement has not kept pace. If it was, then we would not have the shortage. The fact is, if we really lived in a capitalist system, when you have a shortage of something, in this case rural internists, rural pediatricians, rural surgeons, rural family docs, you'd be paying them a lot more than their same counterparts in an urban area. If we truly had a capitalist system, we do not. This system is broken.
Thank you, Matt. So, Dave, let's talk about payment. I mean, you're the guy, you kind of do write the checks, don't you? I mean,
I do sign quite a few checks. Yes.
And you understand this issue. Do you think that in our country it'll come to paying the primary care doctor more, or what's going to happen? Or are they just going to pay everybody else less, or what's going to happen nationally?
In fact, today, as we recruit primary care doctors to a small town versus Sioux Falls, the income offer has to be 20 or 25% higher to get people to go from one versus the other. So it's playing out. I think in the long run, what most likely will happen, and I think will honestly be the healthiest, is that we no longer get paid by procedure, but we get paid to take care of people. And I've thought for years that a patient that goes home from the hospital should have one of our nurses stop by for 5 or 10 minutes that afternoon or the next morning and say, "Are you okay? Did you get your medicines?" We don't do that. We see them the next time they have a problem, and that's, we're problem oriented. And as Matt said, we've got to get to the point that we get ahead of these problems and realize that we have a responsibility to them in between their visits as well as when they come to see us.
Boy, that follow-up visit is so darn important. I wanted to clarify. You said you have to pay 25% more for them to go to rural.
Yes.
Not to go to Sioux Falls.
No, to go to rural. Yes.
25% more.
Indeed.
And you're doing it.
Yes.
And that's going to continue. But, yeah, Bruce.
Well, I was noticing the one question about going to the emergency room.
Yeah. Let me read the question from Marshall, Minnesota. Yeah. I usually just go to the emergency room when I'm ill. I mean, what's wrong with that approach?
And you talked about the importance of that follow-up visit and such. There are a lot of concerns related to just going to the emergency room. It's much more costly, for one thing. But the other thing is the doctor doesn't know you like your personal physician is. It is such an advantage. That's one of the things I like about primary care, is knowing patients over time. I have so much information, not only the chart, but even in my head, that I know about these patients. And it's critical to be doing a good job caring for them.
If you see a person in the emergency room, you don't know them, you start from scratch. I don't care what record you have. You still start from scratch. You don't know them. You do every test. It is not twice as expensive or 5 times as expensive. It is, 10 times or more expensive to have health care through the emergency room.
And some of the tests might have been done yesterday.
And they did it again?
Yes.
Oh, they did?
And without that relationship, the problem is that as an emergency room doc, to stand up for them for a minute, is that they're asked to solve world hunger, basically, for this patient right now.
Yes, that's right.
Everything.
You can't blame them.
That's right.
I'm not blaming them.
You're somewhere between a brain tumor and a sinusitis, and that's it. And I got to figure all that out in the next hour, and it puts a lot of pressure on them. And for those that wonder, why do we charge more in the emergency room as an administrator? Why do we charge more in the emergency room than when they go to a clinic? Well, I have to have the MRI up and running with a person ready to run it at any moment, 24 hours a day, 7 days a week. In the clinic, they don't have an MRI, and they're only open 5 days a week during the day. Yes, and you multiply that times all the technologies. I have 20 or 30 people standing around waiting to do one of these phenomenal tests, which are very important in their own right at the right time. But that's why it costs more. And I wish it didn't, but whenever if you had 20 people in your clinic standing over in the corner waiting to do the next thing, you'd have to charge more too.
And sometimes it doesn't need to be done that day. And if the patient would have waited a week for when the mobile unit comes to their town, it could have been done then.
So I've got, what's the difference between an MD and a DO? And I'm going to just say this pretty quickly. No difference. Used to be, but it's evolved. It used to be a philosophy difference. Anything more than that?
I've always said, I am a DO, so I've always said that the difference is a little bit like the difference between a Methodist and a Presbyterian.
I'm a Methodist.
And I was a Presbyterian. So the fact is, some people think it's huge, the difference, more philosophical. The fact is that the DO profession had focused on primary care for a long, long time. And
more holistic approach.
Yes, but in fact, we take the same boards, we go to the same type of schools, we read the same books, and we practice together. So it's, yes, indeed.
That's right.
Do nurse practitioners and physician assistants have regular supervision with a physician? How much? How often? What's the answer to that? You're the director of PAs.
PAs certainly do, and that's always been the model under which they've operated.
Their name says physician assistant.
Right.
Works with a physician.
Right. Right.
There's a national philosophy with the nurse practitioners. I haven't heard a local nurse practitioner espouse to the national philosophy that is pushing for independent practice.
Yes.
And my only comment is, and I'm married to a nurse practitioner. I work next to a nurse practitioner. I love nurse practitioners. But I have a problem with the philosophy that says, we don't need you. We can practice independently. When physicians who think that have trouble. We need more collaboration in this world. We need not less.
I agree with you, but when you think about the fact that take a town the size of Kennebec, and I love Kennebec, but the fact is that they're not large enough for a physician. They're hopefully large enough for a nurse practitioner part of the time. And the fact is that nurse practitioner that's in Kennebec part of the time is 40 miles from a doctor that is overseeing them. So they're quite independent in their own right. We're asking them to be more independent than maybe they're comfortable with at times.
Right.
But we've got to figure out, like we talked about with rural family physicians, is how do we support them in ways that they can feel comfortable and supported for the challenges that present themselves.
Well, and my answer to you is that if there was a physician in Kennebec,
yes,
that physician should be doing the same thing that nurse practitioner should be doing, which is,
yes,
hey, Bud, Dr. Smith, I've got a rough case here.
Yes.
I don't know what to do. What should I do? I just need to talk it over with somebody.
Yes.
When you're working in Brookings, grab them down the hall. I just need to present
yes,
this case to you. We need to be collaborative.
Absolutely.
And I'm against the idea of, oh, you don't need to have collaboration going on here.
Well, and as I said before, a lot of what we need to do moving forward is to figure out how to manage the care of patients, if you would, together, using the maximum abilities of nurses, of techs, of PAs and NPs, of all of us, so that we fully utilize. Because I think if we were in the middle, as Dr. Bruning said, we're in the middle of a tsunami. If an actual tsunami occurred, we would use all of our capabilities to the utmost to serve our population. And we need to do that today as well as waiting for a disaster to occur, if you would.
Right.
And I think we can learn to do it and do it very effectively.
Well, so a guy named Petersdorf, who is a Harvard cardiologist, I think. I'm not sure. I think he's a great man, a great leader, and he's gone now. But his plan, and of course it was written in the New England Journal, and a lot of people liked this idea, but it fell on deaf ears at the time. And he said, people should have less debt when they come out of medical school. I mean, we'll pay for your way to go to medical school, but you've got 2 years to serve. And we're going to send you, before you do any specialty care, and we're going to send you out into rural or inner city practice and practice primary care for 2 years. Then you can do your specialty, or maybe you'd like to stay there. But that was his plan, and it got thumbs down.
Yeah.
What's your response, Bruce?
Well, there's a lot to be said about providing service, and I don't think it's a bad plan at all.
I don't either.
Yeah.
I think we learn how to take care of people at the most primary levels, because all of medicine, no matter how many tools you have around you, is still taking care of a person who is asking for help. And the ability to do that is primary to your capability to serve them. And no matter what you surround yourself with tools and technology. So I think it's a wonderful idea, and I think you bring back then to specialty education, should you go on, a whole different perception of the fact that I'm here to care for somebody more specifically than I did before, rather than I'm here to deliver a procedure or...
And you'd be one heck of a good specialist after that experience, those 2 years of experience. I think that's a wonderful thing. I don't know if they've considered it. I do think they think it's kind of heavy-handed.
Well, I think that, but you know, obviously you take the debt away. Now, obviously somebody has to pay for that, which means
government isn't going to be happy.
Exactly. No, it won't be their first choice. But
there are any other great ideas?
Yeah, there's a lot to be said about service learning, which is an increasing emphasis in health professions programs now.
And I think, if you really think about it, the people that go into medical school, they start out the most altruistic people in the world.
Yes.
And you know what? They're still altruistic when they get done.
I think so.
I am proud to be in this profession.
One of the things that I've thought about is what could we recommend to a rural town that is looking for a doc or helping a doc, what kinds of things can you think of that would help? And I think as Bruce talked about the rural experiences and trying to help young people come there, and perhaps they can find a little apartment or somewhere where they can go so they don't have to pay for an apartment or whatever, to welcome them to that community, I think, because they are the most welcoming places in the country, and I think that's a positive. The other piece, though, that comes to mind for me is that, and one of the problems we find in recruiting is that with all of the women now in med school classes, which is a wonderful thing, but darn if they don't get married.
Well, and then
now
there's time for babies.
Yes.
What is this?
We're going to have a dating program in the AHEC program.
But you know, when one of the physicians is a primary care doc who would love to be out in a rural community, and the other is a pulmonologist,
then there you have a problem.
They can't go to a very small town.
Or maybe a dentist or an
attorney
or some other professional.
Who needs to be in a city.
So being inventive with how we can find something work for the other person, even electronic types of connections for different kinds of jobs and such, I think can be helpful.
That's great. Yeah. We'll be back in just a minute.
Okay, thank you.
Hanging on the wall of my community hospital is an idealistic image of what it might have been like practicing rural medicine in South Dakota back in the early 1900s. It's a Terry Redland painting of a country doctor's horse and buggy standing outside of a warmly lit farmhouse next to a windless pond with the formation of wild geese framing the sunset. We imagine the physician is inside with his black bag beside him delivering a perfect baby. It is too ideal to be real. Or is it? There is still much idyllic about the world of the modern country or prairie doctor. She or he still makes rounds at the small town hospital every day managing the severely sick, still sends them home to follow later in the office, still has to understand an encyclopedic medical knowledge to kind of nail the diagnosis, and still senses the life story of many patients, having watched and even helped them through the joys and tough times of years of living. The country doc's still around. There are some differences, though, from that painting. Now the country doctor consults the specialist by e-consult over a video screen, co-manages the sickest patient in the hospital with the EICU, keeps up on rapidly changing medical knowledge with teleconferences and internet learning, summons information about medicine side effects through a smartphone, and if needed, flies the emergency crash victim by helicopter to a trauma center, and so on. But as rewarding as this great life for the doctor may be, there are fewer medical students drawn to it, and for many reasons. Now the country doc, called a primary care provider, spends too many hours filling out forms or computer records instead of seeing patients. Is paid less than almost all of the other specialties, and in the larger cities gives up seeing hospitalized patients to the hospitalists. Most of the medical students, teachers, are specialists from the big city, and the list goes on. The country doctor is going by the way of horse and buggy. And the big loser in this picture will be the patient. In both the city or country, especially with all the advances in medical science, we desperately need the patient advocate and coordinator who's expertly trained to know the whole picture of his or her complicated patient. We shouldn't let the idealistic life of the country doctor become just a painting. Well, we've got a few minutes left of some take-home messages.
Importance of having a primary care physician, the fact that the issues are trying to be addressed, by the School of Medicine and the systems and such, and that we'll keep working at it.
I think we continue to work on our electronic connections and such so that we can have information flow to every corner of our area, and every patient has every resource available to them. This brings to a close our show in Primary Care Crisis.
I sincerely thank our studio guests, Dr. David Kapaska, the Regional President and CEO of Avera McKennan Hospital and University Health Center in Sioux Falls, and Dr. Bruce Vogt, the Chair of Family Medicine at Sanford School of Medicine at USD and the Program Director for the South Dakota Area Health Education Center in Vermillion, for helping answer all of the wonderful questions from our audience. Next week, our panel of doctors will address a variety of questions in an Ask Anything format. We recorded it earlier, so you won't be able to call in during the show, but we covered a wide swath of topics. Be sure to join us. And again, I cannot encourage you all enough to get out there and get your flu shot if you haven't already done that. There are a lot of questions to be answered and crises to be met in medicine these days. The great football coach Vince Lombardi thought that no matter what you did, you should do it well. He said, "The price of success is hard work, dedication to the job at hand, and the determination that whether we win or lose, we have applied the best of ourselves to the task at hand." Until next time, stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.